Hi, this is Brian Kim. I'm going to share with you this case of a patient with a rapidly growing conjunctival mass. This patient was in his 50s to 60s, African American gentleman. The patient said it dramatically appeared within a 6-month period. This is a very prominent mass. It's very atypical looking. And so we decided to go ahead and do an excisional biopsy. We did wide margins, no touch technique as much as possible, bluntly removed the lesion, and then I scraped the scleral bed with a crescent blade and then applied 91% alcohol on the scleral bed. Also applied 0.02% mitomycin under the cut edges of the conjunctiva and tenons. So you can see this is a really large mass. It's involving the cornea as well as the conjunctiva. I'm putting in a 4-0 silk suture through the contralateral episclera. I'm rotating the eye temporally with this traction suture to expose the lesion a little bit better. I'm doing about a 3 mm margin from the lesion all the way around circumferentially, and I'm marking it with this marking pen. And actually, I'm taking a pretty generous area across because I have plenty of mobile conjunctiva to be able to reapproximate the tissue. This is topical epinephrine, and I'm injecting subconjunctival lidocaine with epinephrine as well. I'm making sure I'm injecting only in the area where I'm going to be making my incision to remove the lesion, trying to get underneath the conjunctiva as well as underneath the tenons. You can see the lesion is not really moving. It's not ballooning up and moving upward as I'm injecting it. So then now I'm cutting through the conjunctiva and tenons, and then using the scissors only, I'm going around circumferentially with a no-touch technique, just cutting along the marks. It's like using corneal scissors to cut the cornea off when you're doing a penetrating keratoplasty. So I'm just going around circumferentially, making sure I am perpendicular to the incision. And then with the 0.12, so I grab the cut edge of the conjunctiva on the side of the lesion, and I reflect it back onto the cornea. I'm using my scissors to bluntly tease off the lesion, and it just peels right off quite easily. In fact, it peels off even into the corneal tissue. So you can see the corneal epithelium comes off with the lesion here. I don't believe it's violated Bowman's. I think this is just epithelial here. So just tease off some of that epithelium with forceps. And then I'm using the crescent blade to just scrape off the scleral bed in the area of the lesion, and then using the irrigation to flush the eye. So the tissue wasn't infiltrated into the scleral tissue, but it was definitely adherent to the underlying sclera. So a little bit of a concern for me. After I do the scleral bed scraping, I go ahead and do some cautery on the sclera. And then using the forceps, I'm actually cauterizing on the subconjunctival side in the areas that are bleeding. Just going around trying to find the spots that are bleeding in the subconjunctival tissue. Once the bed's completely dry, I go ahead and put my 0.02% mitomycin underneath the cut edges of the conjunctiva and tenons, and I apply the mitomycin for about 4 minutes. And now I'm applying 91% isopropyl alcohol on the scleral bed as well as the cornea in the area of the lesion. And for time's sake, I'm going to speed up a lot of this, removing the plugets out and then flushing the tissue of the mitomycin. And then I'm placing my suture underneath the conjunctiva through the limbal episclera. And I'm going to suture this down. Because it's anchored to the episclera, the conjunctiva will be nice and stable. I'm going to do the same thing on the other side, going underneath the conjunctiva and then through the episclera at the limbus. And this really pulls that conjunctival tissue up quite nicely. Once I tie it down, I'm going to cut the free end, but then I'm going to go ahead and run this suture and reapproximate the rest of the conjunctiva here. It turns out that this lesion was a squamous cell carcinoma, quite an aggressive form of it. Thankfully, the peripheral margins were free, but unfortunately, it did involve the base. And so, because of that, I decided to put the patient also on some alpha interferon topical. I shared the slides with an ocular oncologist, and he felt like there was fairly low risk, and so he agreed with this plan. So, this patient is several months post op now, and his conjunctiva looks normal with no evidence for recurrence. So I hope this was helpful to you, and I thank you for your attention.